So now we come to the last module of our RD Masterclass on tackling PVR and recurrent retinal detachment. This is a very important topic because it is one of the bugbears of all of us as VR surgeons, because it is one of the most common causes of failure of retinal detachment, and it complicates 5 to 10% of cases. It is associated with poor visual outcome despite a very successful surgery in up to 60 to 70% of the cases. And it is basically excessive VR wound healing response. And this leads to the formation of contractile membranes and fibrosis. And this kind of pulls up the retina and causes redetachment. Why does it happen? If we go through the kind of a cycle of PVR, or the stages, it all starts here with the retina break, and then the breakdown of the blood retina barrier, release of RP and glial cells. These are causing a migration and release of interkines and more inflammatory cells. Then what happens importantly is the epithelial mesenchymal transformation and the contractile membranes form. And once these membranes form, they pull on retina, cause reattachment, more breaks, and then the whole cycle is repeated. So let's see what are risk factors, because unless we don't know the risk factors, we don't know how to tackle them. So the preoperative risk factors are like inflammation, vitreous hemorrhage, choroidals, and extensive breaks. More number of breaks are associated with more PVR, and preoperative any PVR. Intraoperatively, if you have any intravitreal or subretinal blood, you're not able to close the break. Most importantly, doing excess of cryo or problems during drainage, these cause PVR. And postoperatively, of course, inflammation is the bugbear. Any hemorrhages, choroidals, multiple surgeries, these all lead to excess PVR. So this is the 1983 classification by Retina Society. And you see they have grade A to D. A is vitreous haze, subpigment clumps. B is wrinkling of the inner retina surface, tortuous vessels, rolled edges of break. And C is the full thickness fixed folds. And C1, 2, 3 are the quadrants. And if you have the fixed folds, you go into PVR stage D, which is a wide funnel, narrow or closed funnel. So let's see some pictures. You can see the rolled edges of the break and retinal wrinkling in stage B in this picture. In the center, you have star fold configuration of the fixed retinal folds in stage C. And now in this picture, you can see the V-scan and the funnel shaped closed funnel configuration in grade D. But there were some shortcomings of this. Basically, it does not distinguish between anterior and posterior. And anterior and posterior both have a little different kind of prognosis or the severity of the cellular proliferation. So Silicon study published a new classification, but it was a little too complex. And the Retina Society again got a revised kind of classification in 1991 to kind of address these issues. And A and B, you can see is the same, but you can see CP 1 to 12, this is the kind of quadrants, the flocas involved. This is the posterior aspect, the P is the posterior, and A is the anterior. And the morphological types within the kind of the types of contraction are there on this slide. Let me show you a few examples. So if you have focal, you can see some focal star folds posterior to the vitreous base here. This is the focal type. In the diffuse type, you can have the confluent star folds and the disc may not be visible like this. Then you can have a lot of subretinal proliferation, the bands. So here you have the subretinal bands you can see beautifully in this picture. When you have anterior, you can have circumferential anterior, which is in this kind of configuration. And then this is the most important, anterior displacement, when you get anterior loop formation. So this is the kind of trough, and anterior loop traction causes the whole retina to be pulled anteriorly. And it's very important to be aware of this. Otherwise, you cause a lot of unnecessary damage to this retina. So once we know what are the risks, we can try to mitigate them. So preoperatively control all the inflammation well, a thorough examination to localize. And like I told you in the beginning, make a good drawing and kind of know where all your breaks are before the surgery. Give steroids if there's hypotony or choroidal detachment. Intraoperatively, it depends on what procedure, like a buckling, again, a good localization, targeted cryo. Avoid doing too much of depression, scleral depression, avoid very prolonged surgery. And during the SRF drainage, if there's hypotony or choroidals, we have to handle that immediately. In case of pneumatic, again, avoid excessive cryo or too much laser. In case of vitreous surgery, we need to avoid iatrogenic breaks and hemorrhage. Adequate vitreous, good base shaving is very important, and do light burns, targeted cryo if you're doing that. Post-operatively, like we discussed, the control of inflammation is the key, and if there's a recurrence, kind of pick it up early and go ahead with the remedial surgery. There are a lot of pharmacological agents. Many of them don't have too much conclusive data, but these include triamcinolone acetonide, dexamethasone implant, antimetabolites, including methotrexate, oral isoretinoids, retinoid, and anti-VEGF agents. So these are some of the agents. And very interesting now, we have the GUARD trial of methotrexate, where serial injections of intravitreal methotrexate 0.8% given post-op caused a statistically significant reduction in retinal redetachment. Only thing is this need to be repeated every 2 weeks, so it is a bit cumbersome. So if we have a PVR, we have to go in a stage-wise way to do the surgery. I always say the first stage should be putting an encircling band. When we do a vitrectomy, put triamcinolone to see what is left. PFCL injection helps like a third hand. And very importantly, bimanual membrane dissection is something which is very useful in these cases. Sometimes if this does not work, we have to do a relaxing retinectomy, after which the endolaser is done and we end with a PFCL oil exchange. What about recurrent RD? So if we have a recurrent retina detachment, this is something which, although with time our failure rates have decreased, but it is a reality as retina surgeons we have to face from time to time, whether we like it or not. This can happen after any sort of procedure, after pneumatic retinopexy, after buccal, or after vitrectomy. The causes are missed retina breaks, new break forming intra-op or post-operatively, development of a macular hole, or most importantly, due to PVR, which we just discussed. So here you can see on this busy slide, the missed break, fish mouthing, the break not being closed adequately, reproliferation, or an inadequate tamponade causing this. Management options, you can do a pneumatic as a rescue, you can do a revision or addition of a scleral buccal, you can do a vitrectomy, or you can peel the membrane under oil. These are the various options you have when you are faced with a recurrent retinal detachment. If we do a revitrectomy, stepwise approach is very important. Anterior segment, if there's a cataract, do the phaco or lensectomy. If the IOL is unstable, remove the IOLs. Sometimes we need to use a keratoprosthesis if there's a corneal haze, or there's a new technique of doing endoscopic vitrectomy. Adding a buccal is something which I always feel helps in these complicated cases. It helps to relieve the circumferential and AP traction. It isolates the peripheral retina from the posterior retina, forming a new posterior ora serrata. And generally, a 240 band is sufficient, but in severe cases or pediatric cases where a lot of contraction, you may use a 276 diode, especially if you want to support a large inferior breaks. When we do vitrectomy, spend some time on the dissecting the membrane, tackle the posterior PVR, the subretinal bands and subretinal oil if there's, you must remove it. Do some ILM peeling at the posterior pole. This ensures that all the traction has been relieved. Anterior PVR we already spoke about in the classification. It is more seen in the vitrectomized eyes because there's a large skirt of uncut vitreous right in the periphery and anteriorly. This needs to be removed. If after all this, the retina is still contracted, go in for a retinectomy. So let's see some tips and tricks about how to handle these situations. This is an occult break, which we couldn't find.
This lady had a recurrence 2 years post silicone oil removal. There was an inferior shallow RD along with previous laser marks, but no obvious break was seen. We tried to locate the break with the help of Schlerine with a brush needle, but we were unsuccessful. We thought out of the box and made a 38 gauge retinotomy and slowly injected subretinal brilliant blue dye. As the dye filled the subretinal space, we had a eureka moment. We saw the blue dye emerge from a very tiny temporal break near a laser mark. Once the break was found, we removed the dye with a brush needle, then performed the fluid air exchange and settled the retina.
So this is just a small tip. Sometimes when you're in a fix, you can't find a tiny break, especially in a recurrent RD. This is a small technique you can use. Other thing is managing the circumferential traction. So this is something which I find useful. This maneuver called tug of war. So you can watch the video.
In these cases, I like to perform a maneuver called tug of war, based on the shearing force a rope undergoes during the game. We use opposing forceps to tug and shear the membranes gently and relieve the traction without resorting to a retinotomy. See this young, highly myopic girl with circumferential traction bands predisposing to anterior PVR. This maneuver allowed us to bimanually release anterior circumferential traction. We took two forceps at 180 degrees to each other, then pulled and shredded the bands holding up the retina. Once the bands were separated from the underlying retina, they could be safely trimmed by the vitrectomy cutter. As the traction was released, the retina fell back and settled without requiring any retinotomies. With a sigh of relief, we performed laser to the attached retina.
This is another bimanual maneuver, very useful for these cases, and this was published by us in the Indian Journal of Ophthalmology. Tug of war, a bimanual technique for anterior circumferential PVR in recurrent RD. So I hope you found this useful, and these are some tips and tricks which will help you go through and manage these complex cases. These are my acknowledgements. Professor Kreisig has been an inspiration, and her teachings on finding the break are always wonderful. Dr. Pramod Bendre was one of my mentors at Shankar Netwale, my whole team at Shroff Center, and Dr. Muni for sharing some of his cases. Thank you so much.